Well, I think we're identifying that CHIP in certain contexts can be very worrisome. So for example, we sometimes identify clonal hematopoiesis in patients who have been treated for another malignancy. And in those patients who have seen chemotherapy, some of the clones that emerge are particularly adverse. So they're clones that carry TP53 mutations or PPM1D mutations or CHEK2 mutations. And these tend to grow and expand after exposure to cytotoxic therapy like radiation or chemotherapy. And they have a higher rate of progression to a frank heme malignancy. Then there are other mutants, like IDH mutants, for example, or splicing factor mutations, that tend to have a shorter latency to develop a full-blown disease and a higher prevalence of full-blown disease that we want to keep our eye on and hopefully potentially intervene on in the future. But for now, we can take patients who have clonal hematopoiesis regardless of the mutations that drive it and counsel them about some of the risks associated with clonal hematopoiesis beyond the risk of developing a blood cancer. For example, patients with TET2 and DNMT3A mutations have been shown to have an increased risk of cardiovascular mortality, and we consider it another risk factor, just like smoking or cholesterol or high blood pressure, that in the future we may be able to intervene upon because we're beginning to understand how it is that these mutations lead to that increased cardiac risk.